Welcome to Bird Ultrasound Case of the Week. You can enjoy similar material by visiting birdultrasound.com.au. This week I'd like to discuss a very unlucky case of a false aneurysm. If you consider our circulatory system, you can break it down into a couple of basic different types. You've got your high resistance arterial system, and this is a schematic that I've made of a capillary bed showing why it becomes a high resistance system. So this could be a femoral artery, and this is in fact a common femoral artery we have playing down here. So you've got an artery coming in, and that artery is feeding a capillary bed. And the capillary bed by nature is made of very small capillaries that really provide a lot of resistance to the blood trying to pass through it. So you've got this quite closed capillary bed system. If you look at the construct of a pulse Doppler waveform, you can break it into systole and diastole components. The systole component is at the beginning of every left ventricle heartbeat. You can see the way the blood rushes forward, and it has a very short acceleration time. You can see the very steep rush to peak systole there. And this component of the waveform, the first component of the waveform, is governed by the left ventricle output pressure and that pressure wave arriving at the point where you're insunating the arterial system. The second part of the waveform, so the diastolic component, is governed primarily by the capillary bed. If you have a capillary bed like in a muscular system like this one, which is a tangle of really tiny little vessels, then it provides quite a lot of resistance to flow coming through it. So when the left ventricle beats, the blood rushes through this arterial system, but it ends up in this myriad of tiny little vessels here, and so there's a lot of resistance as the blood tries to push its way through it, and then eventually it gets into the venous side and empties out into the venous return system here. And that's the type of waveform you expect with something like a femoral artery or an external carotid artery, etc. The other basic type of circulation is a low resistance circulation, and in this we see again that the systolic component of the waveform is governed by the left ventricle output and the fact that there's no stenosis between where this sample gate is placed and the left ventricle. And you can see here that it has a very short acceleration time. It's a very vertical steep stroke straight up to the peak of systole. But then if you look at the diastolic component of this waveform, it is completely different to the one I've just shown you. And in this case, during diastole, the capillary bed is really not pushing back very firmly at all. It's allowing blood to flow through it, and you've got this persistent antegrade flow right through to the end of diastole. And if you look at the schematic I've made here, this is the artery coming in, and then you can see instead of that myriad of tiny little capillaries, what we've got here is quite an open circulation where the arteries turn into veins and everything's of a decent caliber, so the blood can flow through this circulation and then out through the venous outflow side here with a minimum of resistance. And this is what we're going to see with renal artery, and we'd also see a similar waveform in the internal carotid artery. But then there's another type of circulation which is not a natural type of circulation, and this is where there's a closed circuit. And this is what's known as a false aneurysm. So with a false aneurysm, we have an artery, and this artery wall has been damaged in some way, and it's usually iatrogenic through a needle being placed into that artery. As the needle goes into the artery, it of course punctures the wall, but then when the needle is removed, we have a leak from the vessel wall here. And this leaking vessel then pushes blood out through the artery into the soft tissues, and it forms like a little sac, and we call this a false aneurysm sac. Now if you look at the haemodynamics that you have inside of a false aneurysm, it's quite different to the other circulations that I showed you. So during systole, blood will be pumped into the false aneurysm sac, and it sort of swirls around in it, almost making like a beautiful yin-yang type pattern as it goes in. And then during diastole, that same amount of blood, exactly the same amount of blood, then has to come out and comes back into the arterial circulation again. And the reason it has to do this is because we have a closed circulation. So there's no venous outflow here. So whatever goes in during systole then has to come out during diastole before the next systole can refill the false aneurysm sac again. And this is a really important criteria when you're trying to determine if something is a false aneurysm. Now on the video down here you can see beautifully how we've got a femoral artery here, and it's being punctured during an angiographic Seldinger technique, and then as the large bore needle has been removed from the vessel wall, it's left a leak, and we have a very short neck, and this is emptying into this large sac. So this is exactly what we're seeing here on the schematic. If you look here in B mode, you can almost see just very faintly there, the red blood cells tumbling around and around in a circle, and then when we put the colour on, you get this beautiful yin-yang type pattern where you can see the way the blood is literally swirling around inside the false aneurysm sac. Now that swirling pattern is certainly very suggestive of this being a false aneurysm, but the only way to be really certain about a false aneurysm is to have a pulsed wave Doppler of the neck of the false aneurysm. And when we do this and we put the pulse wave Doppler here, where that little star is, what happens is during systole you can see blood rushing into the false aneurysm, and then during diastole exactly the same amount of blood comes out again. So you're getting flow in and then you're getting flow out. Now this is the only type of circulation that can have a balanced amount of inflow and outflow in systole and then diastole respectively, because there is nowhere else for the blood to go. It's a closed circuit. There's no venous outlet from this, so whatever goes in has to come out, and this proves once and for all that this is indeed a false aneurysm. Sometimes the waveforms can look a little bit funky like this one, where during systole a lot of blood rushes in very quickly, so you have like a high peak systolic velocity. It's a little aliasing there as well. But then during diastole it sort of empties a little more slowly, so you get this sort of steep upstroke and then you get this emptying phase here. But if you look at the area that's under this curve here, and then you look at the area that's under this curve here, it's the same amount of blood going in during systole and coming out during diastole. So again, this is really diagnostic of this being a false aneurysm and a closed circuit with no venous outflow. To get these waveforms, it's really important that you put your pulse Doppler right at the neck. And you can see this one has a fairly short neck. Sometimes the false aneurysm will have a longer neck. But when we get it just on the neck, you're going to see this balanced inflow and outflow pattern every time. Now this is the case of a false aneurysm in a shoulder following a shoulder bursal injection. This is the only case I've ever seen like this in my life, so I guess it's not a very common complication. You can see from the video here, the patient's fairly elderly. They've got quite an atrophic deltoid muscle here, and you can see the rotator cuff is in quite disarray. So really what's been performed here is probably more of a joint injection, because this area here that looks like it should be the rotator cuff is really just a bit of blood and other detritus sitting in the space where the rotator cuff would be. But nonetheless, the needle was placed in the usual location, and this would be a bursa/joint injection. Now, if you've got eagle eyes, you'll notice there's a little vessel here, and that little vessel is just sort of sitting underneath the deltoid. I have no idea what the name of this little vessel is. It's just a little artery sitting there, and you may or may not have noticed it during the pre-scan, but the needle has obviously been placed right into this vessel, and then it's led to this hematoma here. Now, this is not just a standard hematoma. If you watch the videos, you can see there's actually flow puffing into this hematoma, and this is indeed a false aneurysm arising from this tiny vessel that's been damaged during the injection. If you put the colour Doppler on it, you can see this sort of yin and yang type flow. It's very, very difficult here to sort of appreciate the neck because it has a tiny neck. It really just goes from the side wall of the vessel directly into this false aneurysm. But I love in the B mode here how you can see during systole, you see the red blood cells puffing into the hematoma, and it's got genuine active flow in it, and this is a false aneurysm. You can see in this nice video how we've now lined up the length of that tiny vessel sitting underneath the deltoid, and you can see the little short neck, and you can see the way that that's emptying the blood into the false aneurysm sac. I love the way that red blood cells are such efficient scatterers of ultrasound, and when we have red blood cells moving slowly like we see here, and sometimes we see it in the venous system as well, you really get an appreciation for the haemodynamics and how sticky blood is and how it moves in a really laminar type fashion. So this is just a really nice example of a false aneurysm created iatrogenically by a needle stick. And now when I do a bursa injection, I'm just having a little bit of a look around that deltoid muscle just to make sure I'm not seeing any other large vessels like this. Although I have to say that since seeing this case, I rarely see any vessel anything like the caliber of the one that we're seeing here. So I think this is probably a bit of an unusual variant of the arterial anatomy that's led to this unfortunate injury to the vessel and then hence the false aneurysm. It just goes to show that even when you've done thousands of shoulder ultrasounds, you're still going to see something unique the next time you put the transducer on a patient's skin. Isn't that one of the wonderful things about the job? Happy scanning, and bye for now.